being recorded because it is a public meeting. The recording will be posted on the Commission's webpage shortly after the meeting. TVW may also be streaming this meeting live and archiving it for additional viewing opportunities. And for everyone's reference, today's agenda can be found under the first tab in the materials. Dave Eisinger, substitute chair for the Universal Healthcare Commission, will now call the meeting to order.
Welcome, Commission members. It's now 2:03 and I'm calling the June 13th meeting of the Universal Healthcare Commission to order. I'm obviously not Chair Lowe, but she is going to be she'll be joining us a little bit later, I understand. And as HCA provides the administrative support for the commission, and I'm also happen to be the agency representative, we thought it would be best and consulted with Chair Lowe about me substituting to convene and start the meeting. So glad to help serve and keep us moving forward. I do want to begin with the land acknowledgement today. Our meeting is being supported physically in Olympia on the traditional territories of the Coast Salish people, and specifically the Nisqually and Squaxin Island peoples. And I want to thank and honor their ancestors and leaders for the longstanding stewardship of the surrounding waters and lands. And HCA is committed to joining these people to share their history, build relationships, increase representation, and restore the living world around us. I want to give a warm welcome to everyone joining us today here meeting at the Universal Healthcare Commission. We're going to turn to tab 1 in our books. And we'll do an overview of the agenda. I'm going to begin with the roll call, or we'll begin with a roll call, but I'd also like to use the opportunity to allow commission members to better get to know each other. Maybe one day we'll all be in person. I'm here in person for our in-person meeting, or for our hybrid meeting. So when your name is called, it would also be helpful to let us all know what fun plans you have for this summer. And after roll call, we will vote to approve the meeting summary minutes for the commission meeting, hear public comments, and then after that, we'll hear from Pam McEwen, our FTAC liaison. We'll then continue our discussion on guidance to FTAC at ERISA. And afterwards, Quinn, HCA's Health Equity Director, will present on HCA's Health Equity Framework for evaluating decisions, which we might be able to use for evaluating commission recommendations. We'll then discuss the revised work plan incorporating evaluation of the Washington Health Trust Bill. And after that, we'll hear from state agencies that wanted to participate in a report out on the 2023 legislative session. Finally, we'll continue our discussion about transitional solutions. And I encourage commission members to ask questions and provide feedback to help with facilitating our discussion. I'm going to turn it over to Mandy to go through our roll call. And again, that question is, what are you doing fun for the summer?
Good afternoon, commission members. I will call members by first name in the order listed in the agenda, which is alphabetical order by first name. When I call on you, please unmute your microphone and let us know that you are here and what fun plans do you have for the summer. And then please mute your microphone again. Chair Vicky. Senator Ann. Senator Ann. Felicia.
Hi, I'm here, and I guess some of the fun activities I'll do this summer are camping and drafting.
Excellent. Dave.
Hi, everyone. Dave Eisinger here again. 4th of July, we usually go down, my family, to the Oregon coast and watch everybody else who's putting off fireworks.
Thank you, Dave. Senator Emily.
Hi, Emily Randall, Senator from the 26th District. My fun plans are I'm planning a wedding this summer.
Oh, excellent. Your own?
Yes, my own. Not moonlighting as a wedding planner.
Congratulations. Estelle? Estelle? Jane?
Hi, everyone. Jane Byer, Office of the Insurance Commissioner. This summer, just being outside, getting up into the high country when the snow melts off.
Joan? Joan? Representative Joe?
Good afternoon, everybody. I'm going to go to lots of parades.
Excellent. Karen? Kristen? Kristen? Representative Marcus? Representative Marcus? Mohammed?
Hi, I'm here. I'm not planning a lot of stuff this summer, but the June 29th is our second Eid, Eid al-Adha. So I'm looking forward to a lot of family and a lot of food in that one.
Excellent. Nicole? Nicole did let me know that she may not be able to attend. And Stella? Stella? Thank you. I'll turn it back to Dave, who will facilitate a review of the meeting summary and public comments.
All right, join me in turning to tab 2 in our commission booklets. This is the recording of the last meeting was posted on the Healthcare Authority's website already, and we're here to vote on approval of last meeting's minutes. So is there any discussion or proposed changes that any commission members have about the minutes? Then is there a proposal that the minutes are accepted without change?
I so move.
Thank you, Representative Schmick. Is there a
And-
second?
Second,
Thank you. All in favor, say aye.
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 Hi.
Any opposed? The minutes are approved. And so next we'll turn to public comment. There are public comments that we've received since our last meeting that can be found in the 3rd tab of our commission book, but we'll open the floor for public comment. We allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide public comment. If you've not signed up and would like to provide public comment, please raise your virtual hand. Mandy will call on individuals after we've heard from the individuals who signed up in advance. When you're called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once, and this will help ensure that everyone or more people have a chance to speak. You're also welcome to provide comments in writing via email anytime. We had a large number of individuals sign up to provide public comment today. So to ensure that everyone has a chance to speak, we have a limit of 90 seconds per person, which will need to be reduced if we get closer to the time limit for public comments. And there are additional individuals who raise their hands and wish to provide comment today. We'll be displaying a timer as a reminder of the time limit, and when the timer stops, please end your public comment. Again, you can follow up with any additional comments in writing after the meeting. We encourage public comments to be focused on the materials or topics that are specifically in the agenda today. And if we run out of time for public comments, again, you are welcome to submit them in writing. Mandy, will you please start with the individuals who signed up for public comment and take us away?
All right, thank you. Mike Benefield? And it does take a little bit longer to transfer people over now because we have new format. So we'll give Mike just a second to join and we'll have to
Oh,
switch people
hello.
from different modes. Hi, Mike.
Mike, we did hear you for a moment, but it looks like you might be on mute again.
Okay, how's this?
Perfect.
All right. Yes, am I on camera or? Oh, doesn't matter. My name is Mike Benefield, and I just want to say that there is a direct relationship between the number of people that die because they can't afford health insurance and the rising profits of the health care insurance corporations. Why do we allow that? The good news is that we have a bill that has been written and thoroughly vetted that would fix this horrible system. The powerful healthcare lobby wants the legislature to continue to ignore this bill, and we can understand why. Saving lives will lower their profits. SB 5335 will save lives. It will save people money, provide everyone with comprehensive coverage, and reduce the state's budget. Please don't ignore this bill. Don't ignore the needs of the people. Thank you very much.
Thank you. Jimin Mason? Oh, I understand. Mr. Mason is not here. Chris Curry?
Hi, I'm Chris Curry from Spokane. Even while discussing transitional ideas, the commission still has not declared with any specificity what it plans to transition to. The most logical transitional goal is for the state to consolidate its existing system that already serves about 1/3 of the population and convert to a single payer system. This means eliminating the waste-generating 11 commercial managed care organizations that are sucking the lifeblood out of our people and converting to the primary care case management model with a nonprofit ACO administration. This will not only save millions of dollars, but it will convince the feds that we are serious and create the perfect foundation for bringing in the other 2/3 of our population. Thank you.
Thank you. Rain Brinkland?
Thank you. My name is Maureen Brinkland, and I've been attending these meetings off and on, and the FTAC meetings as well. And I'm just reminded again about the law that authorized this commission. And you're required to prepare the state for creation of a healthcare system that provides coverage and access for all Washington residents through a unified financing system. And in section 2, it says this system, an inventory in November's report, last year's report, you were required to have an inventory of key design elements of a universal healthcare system, including a unified financing system, including but not limited to a single payer financing system. And I've just been looking at that report, and I can't find key design elements to a single payer system. And I'm just wondering if that is being considered still, if that is part of the long-term goal, and if that is the case, where I might find information on that or hear the commission speaking on single payer. Thanks very much. And thanks for your hard work.
Thank you. I'll be happy to email you that section for you. Now we'll turn to people who have any hands raised. Just confirming it. I don't see any hands raised. Catherine Lewandowski, please.
Hi, can you hear me okay? I'm sorry,
Yes.
I'm not prepared this month, kind of been hit with a lot of life issues going on. But as I was reading all of the reading materials, I did notice a letter that was sent in by one of the public that bothered me a little bit, and it did make me realize that there is some things that are a little bit not clear about Senate Bill 5335 and in regards to Medicare Advantage. And I just wanted to clarify that that really isn't the correct terminology, and we've actually corrected that in language since, and it should actually be Medicare Part C. Because like the for-profit insurance companies, the goal would be for us to best manage Medicare dollars with the most cost effectiveness. But unlike Medicare Advantage, the intent of the Washington Health Trust would be to manage those funds without the goal of maximizing profits for a for-profit corporation. And it's time that it's true that the current Medicare Advantage programs have been used to extract funds for the benefit of those corporations, which is not a good thing. But the intent of the Washington Health Trust is to most effectively manage our healthcare dollars for Medicare recipients and create a sustainable healthcare system overall for everyone in Washington. Thank you for your time and your effort.
Thank you. And Elizabeth, I think I saw your hand raised, but I don't see it raised currently. Would you like to provide public comments? I see WPC Elizabeth.
Hi. My hand is raised. Can you hear me?
Yes.
Okay. Thanks for having me today. I urge you to explore the ways in which a government-run, taxpayer-financed healthcare system is causing hardship in other countries and how other states have abandoned their plans because of the complications. Also, I'm hopeful for a commission comment about the firing of Dr. Johnson and receiving any information about her replacement on the commission. Thanks.
Thank you. Thank you. That is all the hands that I currently see raised. I'm just giving it a double check. I see. Did I miss anyone? I'll turn it back to you, Jim.
All right, I want to thank everyone for your public comments and again, encourage individuals that you can always submit additional comments between meetings and in advance of meetings in writing for review by all the commission members. And next, I'd like to welcome Pam McEwen, our FTAC liaison. That's your current title, Pam, to provide an update to the commission on FTAC's work at your last meeting. So Pam, and I will ask everyone, you can go to tab 4 of our materials. Checking in, Pam, if you are, I think we're
Sounds like she's coming in.
starting.
You are loading me on very slowly. I'm being loaded on very slowly. So here we go.
We can hear you, Pam.
Okay, good. The new system is, I'm sure, is more secure, but it takes a little while to get into the meeting. Okay, so thank you for the opportunity to talk to you this afternoon. I'm pleased to see members of the commission. And what I want to talk about today is FTAC's Medicare recommendations, which we discussed at length at our last meeting at your direction. So we were really fortunate to have Dr. Christine Eibner, who's a senior health economist at RAND and is a member of FTAC, to provide an overview of the Medicare program and the, what we would see as potentially key gaps in affordability and access for Medicare enrollees that they might experience in a universal health system that's being contemplated in Washington. Dr. Eibner outlined 6 different options to address these gaps for Medicare enrollees, and the options were ordered from the least feasible to the most feasible, which is how they're also ordered on this slide. We went through each one of these. Some of them can be paired, and there's a kind of a inverse relationship between feasibility and impact. And what I'm saying is that the easier they are to implement, the less impact they have for enrollees, and vice versa. So as I go through these, it's complex. So please feel free to ask questions, to raise your hand and let me know. And we can kind of, I'm happy to clarify as we go along. Options 1 and 2 are variations on federal waivers. And as the commission is well aware, there is no precedent for a waiver that gives state control over Medicare funds and program administration. Option 1 is an act of Congress or comprehensive waiver that would allow Washington to enroll Medicare enrollees into the universal system and access Medicare dollars. The FTAC members were pretty clear that this represents what they view as a North Star or an ideal approach to addressing gaps in affordability and coverage for Medicare enrollees and getting everyone into a common system. But I think there was strong agreement as well that pursuing this option is not an effective use of resources at this juncture and is unlikely to be successful. Option 2 would involve seeking a demonstration waiver such as 1115 or 402B. This option would allow the state to capture Medicare funding. However, these waivers are generally designed for payment-related reform, and it's not clear how this option could be leveraged to cover premiums or cost sharing or the additional benefits that Medicare enrollees would be receiving. These waivers also, they require significant oversight and evaluation by the state throughout implementation, and they include budget neutrality requirements. The FTAC members did not view this as a viable option for achieving the goals of the universal healthcare system, given the intent that these waivers differ from what the commission is trying to achieve. This option could complement and be explored in the future to reduce costs of a payment model, which will be significant as we consider universal coverage. Any questions on that section so far? Okay, options 3 and 4 are variations on a state-run Medicare Advantage plan. In option 3, Washington would design and implement a Medicare Advantage plan for state Medicare enrollees. The plan would provide comprehensive benefits parity with the universal system and would be the only option available to Washington's Medicare enrollees. Allowing only one Medicare Advantage plan operated by the state would require a federal waiver from the provision that allows for choice and a way to preclude new plans from entering the market. This option would be subject to legal challenges and Medicare enrollees aren't allowed access to traditional Medicare. The state would also incur additional administrative costs to develop and oversee or potentially contract with the Medicare Advantage plan. FTAC members agreed that it's difficult to envision how the state could legally implement this option, given the barriers to obtaining a waiver that would limit freedom of choice. Some members stated and believe that while it doesn't make sense to expend resources on this option at the outset, there may be a pathway here in the future once the value of a universal system has been established. Option 4 involves the same scope of work to design and implement a state-operated Advantage plan, but this plan would compete with other private Medicare Advantage plans and traditional Medicare would continue. Option 4 doesn't present as many legal hurdles as option 3 because it preserves Medicare enrollees' freedom of choice. FTAC members' response to this option was mixed. The state would face significant competition by entering an already very mature Medicare Advantage plan market with 18 carriers and over 100 Medicare Advantage plans, where Medicare enrollees could potentially choose other Medicare options other than the state's plan, limiting the overall impact. FTAC did not recommend this option being taken off the table, but felt there may be a possibility for this option to sit along option 6 in the future. In option 5, the state would develop and offer a Medigap plan to fill in gaps in benefits between Medicare and the universal system. While this option seems the most feasible in terms of existing legal authorities and is less burdensome for the state, members were concerned that this option would not achieve benefits parity with the universal system. For example, hearing, vision, supplemental drug coverage could not be included in the plan, and these benefits are likely to be included in the universal healthcare system as it's being contemplated. This option would also not capture federal funds and would not be available to Medicare Advantage enrollees. Additionally, under this option, the state would enter a mature market and need to compete with other Medigap plans. There was some interest in this idea as a possible short-term option, potentially paired with option 1 or 2 in the long term, but the majority of FTAC members do not support option 5 at this time. Finally, under option 6, the state would establish a system to directly reimburse Medicare enrollees for cost sharing and for services covered by the universal system, but not covered by Medicare. This option allows the most flexibility to fully address gaps and would not require waivers nor result in legal challenges. However, federal rules could potentially limit the ability to wrap around Parts A and Part B. This option may also invite gaming from MA plans and may be administratively burdensome for the state and consumers. Federal dollars would not fund these additional benefits, placing the financial burden on the state. However, FTAC members agreed that at this time, option 6 presents the best and most feasible pathway to address gaps in cost sharing and benefits for Medicare enrollees. FTAC noted that that revisiting option 6 with further analysis and decision-making will need to occur after the commission has determined the services and benefits of the new universal healthcare system design. Until then, further analysis to determine what gaps need to be filled between existing Medicare services and benefits and the service and benefits of the new system design is not possible. There are additional considerations noted in the Medicare memo, which I urge you to take a look at if you haven't already. Are there any questions? It's a lot of material, a lot of decisions, a lot of discussion.
Pam, this is Dave. I think it'd be good if you defined a term, because I don't want anyone, public or commissioner, to assume what certain words on the page mean. And could you elaborate a little bit about exactly what state operated looks like or means for options 3, 4, and 5? Because there's, in my mind, there's a range of, that means self-insured, but there's a contract and somebody who isn't a state employee is doing the provider networking, doing the claims adjudication, doing the prior authorization. And then there's the other side of the spectrum where state employees literally do all of those steps. So could you tell me or tell everyone a little bit what state operated meant for FTAC?
Yeah, I can give that a try, Dave. And but I will tell you that we were flying at 30,000 feet as we looked at these things. So we weren't diving into kind of a detail of imagining what they would look like. But a state operated Medicare Advantage plan, for example, could mean that, like, comparable to the basic health plan, this is a state run program. It could also mean that the state would contract with an existing provider to run a state program under kind of a state contract with state defined processes, benefits and so forth. Does that help?
That does. I just wanted to elucidate that for everyone's benefit.
Yeah, that's good idea. Thank you.
So Pam, question on option 6.
Mm-hmm.
So I'm sitting and thinking, like when we talked about federal funds being available, if this is wrapping around Medicare and it's sort of independent of Medicare, then somebody who's on Medicare who's currently eligible for Quimby Swimby, right? The premium subsidies and other financial supports that lower income Medicare beneficiaries get, those could stay in place, right? Because
Right.
I'm enrolled in Medicare.
Right.
So we'd still get federal dollars that way. But is the thought that because we're wrapping around to bring the benefits up to whatever the benefit package would be in the new system, that would depart from the A through M or however many standard plan designs there are for Medicare supplement coverage? So it's actually something other than Medicare sub coverage?
Right. I think it would, Jane. I think, and this is, I would welcome the staff who worked on this with the committee to also jump in. But if you think about the gap is a design, in theory, this universal system, and then as a Medicare enrollee, I don't have the same benefits. Therefore, I'm eligible for a wraparound service similar to what Vicki Lowe described to us in their health system. So what you can have, and this is where I think the reference to gaming was mentioned here, is that you could end up with kind of almost incenting private carriers to back off some of the benefits they offer. But and also this is where the administrative complexity comes in, is people have all different Medicare arrangements. Actually, some are through employers, some are through Medigap. And you read kind of A to Z. It's not literally A to Z, but it feels that way when you see it described. And in addition to Medicare Plus Choice, which also has everything from gym memberships, and enhanced drug benefits. So it's very complex, but it is a way to achieve equity. And it was seen as paired with number 1, which is that while you wait to be able to pursue a waiver, which would be a much simpler approach, number 6 can be used to address equities and gaps within coverage.
So it sounds like it could either be I'm in traditional Medicare and I don't buy a med sup plan, and the system is filling in the gaps between traditional Medicare and the universal healthcare benefit, versus I'm on Medicare, I have a Medicare sup I still have gaps and the system's filling in those gaps.
Mhm.
Right? And then
Right.
I agree with you. I mean, the variability of benefits that are offered by the MA plans is it's so hard.
I know, it's staggering.
It's harder to figure out what you're supplementing there than it is, I think, with a traditional supplementing a Medicare supplement, but yeah, you're right.
Right, and I don't want to jump ahead of the committee and what we've had the opportunity to discuss, but in theory, the state could draw a line and say the really obvious things are hearing aids and the enhanced drug, but with these things are obviously otherwise,
And
you
vision.
put those other things on the market, we're not going to fill in for those things. And that would probably be an obvious direction for the state to head.
Yeah. Okay, thanks.
Yeah. Question?
Yeah, I have a question. I'm wondering a little bit more about, or if you could tell me a little bit more about option 2, the demonstration waiver, why it was considered not feasible. I was thinking whether it could be combined with option 6. So, thinking about, okay, these are some of the services that we would like to provide that is not currently provided, and could that be, put forth as a demonstration?
I think so. I mean, I think there's potential to do that. The other areas that in terms of looking at cost sharing and looking at other issues in terms of payments, there's also other opportunities to pair with 6. I think it seemed like a lot of effort to obtain a waiver that might potentially not address the problem because of how these waivers are designed. But if you look at pairing it with another one, and this is, I think some of the committee members came up with the same thing that you just asked about, that there may be some potential to get some benefit from this.
Thanks. I mean, I think option 6, like you said, it's most feasible, but the problem is also a very big one, that we cannot capture the federal dollars. So
Right.
kind of if it is possible to pair it with a demonstration waiver, then at least that can be done, that the federal dollars may be captured.
Right, that's a really good point. Other questions? Okay, it was a really excellent discussion about an incredibly complicated topic that you gave us. We were happy to wade through it. I'll be interested to hear any feedback from the commission members. And then next up is our work on ERISA, and we will also be looking forward to direction from you and as we approach this topic as well. So thank you very much.
Thank you, Pam. Just want to check in. I think we have a action scheduled on the recommendations that are before us. And so I think we're looking for, I was just waiting for the slide to catch up to the words I was looking for. So Pam just walked through the FTAX Medicare recommendations, and I think we're hoping to take a vote today, possibly to adopt those Medicare recommendations. So I wanted to acknowledge a couple of commission members who have joined since the beginning of the meeting. I see Representative Richelli, and I also see Joan. Are there any other commission members who joined after the roll call that I'm just not easily observing? I just want to make sure the record reflects who all's here. Okay, so adding Marcus and Joan to the roll call, so to speak. Is there any discussion or a motion from a commission member related to the Medicare recommendations that Pam presented on behalf of FTAC?
I just have a quick question about the exact recommendation. Is the recommendation that we consider the 6 options like a broad, just or is there that we only consider option 6 as the most feasible?
That is a great clarification, Badisha.
I can speak to that. This is Angela Castro. I staff FTAC and Pam. We can jointly do this too. That FTAC's recommendations were that 6 was the most feasible, that it's possible to be combined with the demonstration waiver long term, but that further exploration does need to be done on this once benefits and services discussions have been had and determined by the commission. Pam, is there anything that I left out? Oh, Pam, you're muted.
Thank you. I think that we did see these as paired. You almost have to step through them, beginning with the most feasible to address equity, and then you look at pairing with either 1 or 2, which are the federal waivers to, as you said, to recoup federal funding and to start to move to more of a universal system that's simpler to operate. But it's hard. These we didn't see 6 as standing alone indefinitely, but that was more of a way in to begin to work on the issue of covering Medicare enrollees. And we need much more information. This is a topic we're all going to have to come back to.
So I'll take a stab at describing what I think the motion is and then ask if anybody wants to move to adopt what I'll describe, which is to accept FTAC's recommendation related to number 6 being the most feasible, with further exploration and possible combining the demonstration or federal waiver under options 1 and 2. Is there a motion to adopt, to move that adoption of that?
I think, Dave, friendly amendment that.
Sure, or just make a motion directly, Jane.
Well, I can't repeat everything that you said, but friendly amendment being that we also have a willingness to come back and revisit, as Pam indicated, once we've got guidance on covered services, right, cost sharing, that the universal system would have, because then you know what you're measuring to try to get to, right? Like Pam said when she was talking about equity, then we can quantify what it means to look at the difference between what Medicare currently covers and what would be covered under the system. So basically just saying yes to what you said and also acknowledging that we would want to take into consideration the commission's recommendations with respect to covered services and cost sharing for the universal system. Does that make sense?
It does. I was trying to boil that down to a few words to maybe repeat the idea.
Just trying to phrase this back to you, Jane. I worry that that doesn't adopt a recommendation because it's sort of like still circles back around to some of the enrollment topics that were sort of potentially like options 1 and 2 that were not feasible right now. Could say at this time, potentially.
Okay.
Jane, are you saying that you just want to be clear, kind of like what Pam said, that the conversation about how to fill the gap will happen after the benefits and services are determined? We will have the conversation at that time. Because right now we don't know what gap we're filling.
Right. Thank you, Liz, for thinking for me.
Right.
Since we haven't actually had a moving of a motion yet, I have another idea to maybe get us going. In our materials, there's a 3-page document that FTAC has produced that we're reviewing. We could have somebody move to simply adopt that guidance in that 3 pages that's provided to the commission. That might be a cleaner way, and it kind of captures a lot of the variability that's being discussed right now. So that's another suggestion if somebody wanted to move that. I did see our FTAC liaison smile when I said that, so I was thinking maybe that was a good, maybe that
Dave,
was
I was thinking something similar. This is Joan from the Exchange. I was thinking something. I see hands are up, but I was thinking something similar, like, can we move to I really appreciate the work that was done. This is such a massive topic. So I think you're seeing the commission struggle a little bit with like synthesizing it all in real time. But I appreciated the document. I thought it was an excellent summary, and to the extent that that laid out feasibility of the various options and where the commission would kind of focus their effort in conjunction with like moving forward and looking to see how it fits with all the different pieces that are going to be brought back to us. I think that makes sense.
Was that a motion, Joan?
I don't know. I saw a hand up, so I wanted to defer since I jumped in San's hand.
It's my hand, sorry. I would just say this. So I loved that 3-page because it was condensed and it gave me a very good idea, like, you know, having 6 options, these are the things, these are the advantages and disadvantages. So I agree with Dave. I would just make one small critique because it seems option 6 is the best option right now. The only language missing is combining option 6 with something else. That language was there for, say, options 4 or 5, but if that could be added to the guidance, because going forward, I feel like that's where we will come back again and again, then yes, I agree that let's first say that or vote on adopting this as a guidance. Does that make sense? Sorry.
Yeah, I want to just add, make sure I'm not muted, that I like that. I think that the intention was exactly as you said, which was the pairing between 6 and the federal waiver. And I think that was intended in saying that this, you know, the waiver was a North Star. So I think that your suggestion makes it more explicit. So I think that would be, I think that's a good idea to make that very clear.
Okay, because I did see that exact sentence, like pairing for option 5. But I didn't see that language for option 6, and that's the only sentence I would add, potentially pairing option 6 with option 1.
Coming from FTAC, I support that. I think that clarity will be helpful.
Is there
Motion? We still don't have a motion.
yes, is there a motion, Vidisha? She has a motion to amend.
Oh, there's no motion yet.
Oh,
I've been suggesting
Oh, that's
people.
right.
Yeah,
make
let's make a
Sorry.
motion. I believe in us. I think, Vidisha, the motion is to adopt the recommendation from the FTAC with the clarification that 6, you know, could be explored in conjunction with one of the waiver options consistent with the FTAC presentation today.
I agree.
Is that as a motion from Joan? Vidisha,
Yeah.
was that a second?
Yes, whatever, whichever way, but yes, that's,
Great.
I second what Joan said.
Great. So we have a motion from Joan, a second from Vidisha. Is there any discussion on that motion?
We pre-discussed, Dave.
I would say we discussed the motion before a motion existed, but it got us to a motion. So if there's Representative Schmick.
Thank you. I'm still going through the recommendations. There's some basic questions that I don't think that have been, at least to my satisfaction, haven't been addressed. And I am uncomfortable moving ahead, I guess, without at least consideration. And part of it, I probably haven't reviewed the materials, and I'll admit that as thoroughly as I should have. But I think that there's some basic things that we still haven't addressed. First of all, who's in, who's out? Who does this cover? Who does it not cover? What is the intent? For the most part, federal government, when they give waivers, they agree to a certain amount of maybe increase, but overall, they're going to want to invest less dollars, not more dollars. And so I guess that leads to, what are we going to ask the Washington state taxpayer to pay, and how much more? That one I struggle with. So, and it was brought up about the definition of services. What are we going to cover? What are we not going to cover. We're making recommendations, I think, without, I think, some basic things that I would sure like to see discovered. Now, again, I freely admit, maybe I've got the cart before the horse, but I think that these are basic questions that it would make us able to vote better because we'd have more information. That's my comment. Thank you.
Yeah, Dave, one of the things I really appreciate Representative Schmick's questions. I think they're not dissimilar from questions FTAC was asking as well. We felt like there's kind of a chicken and an egg, like who do you want in? What are they in for? And we also start to feel like we could keep going around that for a long time. And that what we're trying to do with these recommendations in some way is to give you something so that you can kind of set it on the shelf and get to those other questions. But it's not set in stone to the point that you can't come back to it. So that's what I like about looking at the guide, thinking of it as guidance, so that we think of it equity issues that we want everybody to be covered. We want to capture whatever federal dollars that we can. And some of these things we can't know clearly until we know exactly what it is will be included and what the gaps could potentially be for people who are in Medicare. I don't know if that helps or not. I'm trying to help.
I was going to ask if is anyone, and I was going to include you as a respondent for additional context. We are still in our kind of motion adoption process. Are there other discussion points from commissioners?
So Dave, this is Jane. I guess, and I agree with Pam and Representative Schmick that it's hard to know what you're solving for in terms of what you want to do for Medicare beneficiaries. And I think one of the reasons, and you can correct me if I'm wrong, Mandy, one of the reasons that we asked the FTAC to look at Medicare early was to give us a sense of whether in our design work, we wanted right off the bat to assume that Medicare was all in, that we were going to get a massive waiver and build this system on that assumption. And I think having what the FTAC came back with says to us, probably safest not to make that not to start with that assumption. And as Representative Schmick said, to figure out who's eligible, to figure out what benefits we want to provide, look at it from a context of having equity as between folks who are on Medicare and folks who aren't. And then once we know how big that bread box is, come back and, like Vidisha said, explore whether looking at a bigger waiver makes sense at that point. Pam, did I articulate that correctly in terms?
Yes.
Okay.
Yeah.
Any other additional comments from commission members? If not, I'm going to call the question and ask for all in favor to say aye.
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 And any opposed?
Representative Schmick is voting opposed at this time.
Thank you. And any abstentions? I believe that the motion has passed. Thank everyone for the discussion. Thank you, Pam, for reporting back on FTAC and your continued work. We're going to transition to our next agenda item, which is continuing to talk about FTAC and guidance from the Commission on ERISA. And so, Liz, take it away.
Everybody, it's good to be back with you. If we can go to the next slide, Angela, thank you. So now that FTAC has completed, for now, it's providing some guidance and input to the Commission on Medicare, it's time to shift to ERISA, and another population and group that we want to provide some insights about how to address them. And I think, as Jane put so clearly, Are we designing around this, or are we kind of putting it on the shelf for now? Trying to provide some basic input on that. So if we can go to the next slide. There was a brief discussion about ERISA at the April meeting. And here are some of the key things that emerged from that conversation that the commission started to articulate that they wanted to hear more about from the FTAC. Knowing more about pay or play options where employers have a choice to continue being engaged, providing coverage to employees, or an option where employers pay into the universal system. They wanted to know more about how ERISA, the ERISA law has evolved, and if there's anything changed since the last evaluation on it, and if there's any new approaches. And then finally, FTAC wanting to know if FTAC could look at how employer contributions could be captured under the different options, similar to what we just talked about with Medicare. So that was what was put on the table in April. And we just wanted to spend a few minutes asking all of you, when FTAC picks this up in July, what are other things that you want to know about in terms of ERISA? And this, again, this will not be the only time Pam is coming to talk to you about FTAC. Our work plan calls for at least 2 meetings focused on this, but for now, we just wanted to provide an opportunity for this discussion.
So Liz, question just to clarify, on the second bullet, an option where employers pay into the universal system and employees are covered by the universal system, is that akin to what Oregon came up with, where you've got an employer payroll tax, the employer pays that payroll tax and then can make a decision about whether that's all they're going to do or whether they might choose to supplement it, for example?
I think it's both. It's the whole like realm of options.
The whole realm of options
around like taxes, and I'm trying to figure out how to say what it is that I want to say. Why don't you talk a little bit more and maybe I'll be able to clarify.
I'm just looking at the distinction between the first and the second, right?
I think that they fit together, but it's in terms of the play option. They're similar to what we just did with Medicare. There are different options within that. Is what I took this as. I was not at the April meeting, but I think that basically, pay or play and what exists underneath that. And I see Representative Schmick's hand is up now too.
I just had a question. Since ERISA is federal law, and we can't trump that.
Right.
Is this what we're talking about, just to clarify, those ERISA plans that are regulated by ERISA rules, we're going to allow them an option to participate? Or I'm trying to get a feel for this, since ERISA law trumps what we do.
Okay, I'll come back to that. Mohammed, you have a comment too?
Yeah, I just wanted to add, if, for example, so one of the discussions that we've had in the past is we're in addition to getting the people of Washington universal healthcare coverage, we're also looking into improving the quality of coverage. Basically giving them something better than what's available. The employer pay or play, I see a problem there where different people have different coverages and they're not the same. So is there a standard that we have to meet? And then also, is it going to be the same cost to the employer as it is right now, or they will have to be mandated to pay more or less? So kind of a couple of questions there for me as well.
Okay. And I mean, I think I appreciate that. So I'm not going to answer these questions now. These are just questions that we're going to explore in the FTAC. And Gary, my colleague, has a comment in response to Representative Schmick as well.
Yeah, And to Jane's question, I think what we're looking at, because Representative Schmick is absolutely right. The state can't directly regulate ERISA plans, but one option that has been discussed, not just in Washington, but more broadly, would be a payroll tax that would provide an incentive to employers that rather than have their own plan to pay, have a payroll tax, and then their employees would be in the universal healthcare system. And I think the difference between 1 and 2 is whether you just give employers a choice and say either pay the payroll tax or continue on with your existing coverage. And then number 2 is no, we're going to, the goal is really going to be to end ERISA plans by having a payroll tax that would make it so that employers would not want to pay twice. They wouldn't want to have their own coverage and be forced to pay a payroll tax to pay for the universal system. So option 1 provides more of a choice to employers than option 2. That's my understanding.
Thanks, Gary.
This is Dave. I don't know where how well this question fits, but I can't get it out of my mind. When I see pay or play, I think about Affordable Care Act reporting and employer offers of coverage and failing to offer coverage. And if somebody ends up getting a subsidy on an exchange, then small and large penalties. And it got me thinking in this world of the first 2 questions that are being explored, where would what are the implications for like ACA coverage penalties if we ended up in a world with a payroll tax and there was not something else? It just got me thinking about the intersection with ACA employer responsibilities. And so I just wanted to throw out that my mind was going in that direction, and it might be a relevant question that I haven't heard somebody ask before.
Great. And we will add that to the list. So I'm assuming Angela's taking notes on that. Jane?
Yeah, Dave, I think your point is well taken, right? Because under the ACA, the employer's obligation, if they have 50 or more employees, is to provide a benefit package that has a certain actuarial value, right? Minimum essential coverage. And the assumption, I think, would be that, or this is to take it back to the FTAC, would the assumption be that if you're going to do a pay or play mechanism, the question is, if the employer chooses not to pay and to continue to offer coverage for their employees, is there a minimum standard for what they have to offer? And is the minimum standard the Affordable Care Act, or is the minimum standard whatever the benefit package is going to be in the new system?
Great clarification, Jane. Thank you.
Yeah.
Other commission responses for Liz and Gary to take back to FTAC on this topic? All right. Well, if anyone thinks of anything, you all know how to contact HCA and get to Liz. So I'm going to move us on to our next topic. So thank you, Liz, and I'm going to welcome Quinn from she's HCA's Health Equity Director to present on the agency's health equity framework that is used for evaluating decisions, which we'll consider using for evaluating commission recommendations. So Quinn, welcome.
Thanks so much, Dave. And thanks for having me here today. I just realized that the PowerPoint that you have up right now may not be the one that I just sent recently. So can I just really quickly confirm with Mandy that you have that one that I sent about an hour ago, 2 hours ago?
Do you have it, Quinn? We can switch slide decks. Hold on just 1 second.
I emailed, yeah, I just emailed it to you right before the meeting. Apologies if it's a different deck. I don't remember.
You're fine, Quinn. We got it. Don't worry about it. I just sent it in.
Okay, great. So I can just go ahead and get started. So good afternoon, everybody. I'm Dr. Quinn Huynh. I go by Quinn. She, her pronouns. I'm the Health Equity Director for HCA, and I'm a family nurse practitioner by training and an academician, having spent the majority of my career in underserved communities, Although HCA has always pushed to advance health equity, the concept or even the vocabulary equity is fairly new in this country and needs a lot of development to ensure that it brings our existing work to that next stage. Today, I'd like to share with you some information about HCA's equity framework and current efforts. And Mandy, I'll let you share the screen whenever you are available, but I'll just keep going until you are able to pull up that PowerPoint. So you already know a lot about the Healthcare Authority, but just as a reminder for those who are on the call and wanting to know a little bit more, we are responsible for purchasing care for 1 in 3 non-Medicare Washington residents. This includes all of the programs under Apple Health and the Public Employees Benefits Board and the School Employees Benefits Board programs. This makes up over 2.5 million Washingtonians. And then we also have the behavioral health services that serve all 8 million Washington residents. And our agency has 18 internal divisions with over, now my count is 1,600 employees. We're on the 3rd slide now, if you're following. Thank you. So our approach to health equity, to healthcare is to purchase healthcare in a transformative way. We want to do it with the whole person in mind, and we want to do it with evidence to inform us. We transform care through pushing for better care and outcomes at a lower cost. We integrate physical and behavioral health. Our annual budget is anywhere between 17 to 18 billion dollars. So it's really imperative that we must be good stewards of this funding. And one way to do this is to ensure that we have an equity lens at the center of our vision and mission and strategic plan. So on this slide here, you can see that our language for health equity is based on the Robert Wood Johnson Foundation's definition of equity. The picture that you see on the right is a picture that speaks to the difference between equality and equity. Equality is everyone, or in this case, every plant gets the same environment, same weather, same soil. This can result in a very happy cactus, a semi-okay flower, or a dying plant. Whereas with equity, each of these plants will get the environment that best fit their needs, whether it's a different amount of sun, of rain, or the soil quality, so that they can all thrive. And that's what we need to do here. We need to promote an environment in which everyone has the opportunity to be as healthy as possible. On the next slide, the timeline speaks to our history and the equity related work that we've embarked on. I will only focus on a couple areas. In 2015, we stood up the Accountable Communities of Health. They are 9 nonprofit organizations representing 9 geographic regions of Washington state. They are the liaisons between government and the communities. In 2016, we implemented the Medicaid Transformation Project, and this derived from the ACA. In 2018, the Division of Behavioral Health and Recovery became part of our agency. Therefore, it expanded our services to all of Washington. And then last year, we launched the PAIR work, which is Pro-Equity Anti-Racism, aka PAIR. This is in conjunction with our renewal of the Medicaid waiver. So I'll talk more about those later. Not listed on this timeline is in February of this year, President Biden issued an executive order on further advancing racial equity and support for underserved communities through the federal government. This is important because it emphasizes the needs for changes in government at all levels. So on the next slide, and then we'll skip to the next one. Historically, HCA has always done equity work because Medicaid is a tool to support underserved populations. However, as of 3 years ago, there was no standardized and unified process throughout all 18 divisions in our agency, and there wasn't a dedicated FTE for health equity. On the next slide, you'll see that we began formalizing this work through creating FTEs and to build new infrastructure. In 2021, we began creating these new positions called the Health Equity Liaisons, where each of our 18 divisions have to have at least 1 or 2 people to serve in this role. And the liaisons serve as a bridge for their own division and to connect the equity work across the agency. they're responsible for communicating and the training and the alignment of each of the division's equity efforts with other divisions, and they serve on various committees. Next slide. You'll see that by the end of 2021, we added a new sentence in all of HCA employees' job description, and it says that HCA employees will apply an equity lens to their work, which may include, but is not limited to, all analysis of core business and processes. So alongside that, we also created a health equity toolkit that helps our staff to apply that equity lens when they design or evaluate policies, programs, and services. This includes identifying and addressing the disparities during legislative session. This is when we give input on hundreds of bills. Adding this equity lens has shown a difference in how we evaluate and support bills. This toolkit requires us to take a deeper dive in thinking about the consequences, especially unintended consequences of our work. This toolkit also emphasizes impacts on tribes and indigenous peoples, which are often forgotten in government. Next slide. As part of that infrastructure building, we also created an internal equity inventory and dashboard where we collect and track and view all equity related work that are taking place at HCA. We currently have a database of over 100 initiatives. Our staff are able to access this database to research past and existing work to find opportunities for collaboration and alignment. And therefore, we're hoping to reduce waste and duplication of efforts. We also created the collaborative community for health equity, where all HCA employees are invited to attend once a month to learn and share best practices and resources. And we are in the process of designing a series of health equity training modules for all staff that will launch in the next few weeks here. Next slide, I want to switch gear and talk about a different initiative. In 2022, our governor issued the Pro-Equity Anti-Racism Executive Order, also known as the PAIR framework. This requires all state agencies to have a plan to become pro-equity and anti-racist. One of our accomplishments was the establishment of the PAIR Community Advisory Team, also known as PAIR-CAT. This team is comprised of a lot of different community members who advise our internal work. We want to engage with and hear from these underserved and underrepresented communities, including communities that are Black, Indigenous, and people of color, non-English speakers or English as a second language, immigrants and refugees, and LGBTQ+ communities, amongst many others. We hold regular meetings to share information and discuss high-level strategies with PAIR-CAT. Government communications with communities have historically been to just inform the communities. However, with PAIR-CAT, we're hoping to get to a point of collaboration where our work is co-led and the power that we have is shared between government and communities. You know, Vicky Lowe, the commission chair here, is actually a member of our PAIR-CAT, PAIR Community Advisory Team. Next slide. The PAIR and PAIR-CAT teams have identified 4 key areas known as work streams that are focusing, that we are really focusing in 2023. And they are community engagement, which is not to be mistaken for stakeholdering. And I find that a lot of people will mix the two quite a bit. So community engagement is not the same as stakeholdering. And as of Monday, June 6th, so last week, we launched the first community engagement mini guide. This guide provides information on how HCA can engage communities in all of the various work that we do. The second work stream is data equity strategy. We want to be sure that the work that we do is backed by data and that data tells the true stories of the communities. So for example, data may show that there are a lot of Black men in prison. However, this data is dangerous because a person can look at this data and interpret it as, well, Black men are more prone to crimes, thus they are more likely to be in prison. That's not true. When the true story is that Black men are more targeted by our legal system and are more likely to be imprisoned for things that white men don't have to be. So data equity strategy provides that data as backbone and benchmark to keep us accountable for our work. And third, leadership and operation strategy is used to enhance our health equity. We have to have clear buy-ins from our leadership and this must be reflected through our daily operations. Finally, the workforce equity workstream is not only focusing on our internal HCA workforce, but we're looking at Washington State's healthcare workforce as a whole. We are exploring ways to create a healthcare workforce to serve all of Washington, especially looking at rural and underserved populations. So next slide, all of the things I've mentioned in previous slides are really internal infrastructure building that will stoke the external results. Next slide. So HCA is making intentional efforts to address health equity, diversity, inclusion, and belonging. And we do this through applying that lens that I talked about. This list is really long, so I'm just going to name a couple different items on here. We continue to build our value-based purchasing strategies. We focus on quality and value. We're renewing our Medicaid waiver with a focus on equity, focusing on lowering healthcare costs for consumers and increasing transparency, as you can see here as part of the commission's work. On the next slide, there are some examples of social determinants of health initiatives that we are working on. This includes identification of needs through managed care organization screenings, measuring disparities in quality measures, building guidance for health-related social needs, and many other things. We embed equity through financial incentives. For example, we require certain quality metrics to be met in order to receive financial incentives. Next slide. We also cover services like transportation, interpreter services, health homes. Most recently, we have worked on foundational community supports for housing and employment, the food security, and medical respite. Another social determinants of health initiative is the investment in our core infrastructure, such as the community information exchange or the community hubs that the Medicaid waiver is focusing on. We are also looking at equity investment programs. We are building a community hub as a centralized entity that connects our patients to the resources. And then we work closely with the communities of health just to strategize on equity investments where the communities are able to identify issues and formulate solutions at the grassroots level. Next slide. We are heavily involved in other agencies and national partners. I serve as a council member on the Governor's Interagency Council on Health Disparities. This council is responsible for identifying priorities and creating recommendations for the governor and legislature with the goal of eliminating health disparities in Washington State. Our involvement with national and regional entities also help to advance health equity through multi-state learning collaboratives. Together, we come up with best practices and provide recommendations to state Medicaid agencies in all 50 states. We focus on tribal implications to ensure that there is appropriate government-to-government collaboration. We work closely with our Office of Tribal Affairs. We all know that Native Americans have suffered terrible injustices at the hand of the U.S. government. So we have to pay special attention to that as part of this equity movement. Next slide. We understand that we have to work differently in order to create different results. We are centering diversity, equity, inclusion, and belonging at the state Medicaid agency level. We're committed to working with and for the communities, and we continue to engage communities through this lens to ensure that those most disenfranchised are going to have a voice at the table. Next slide. So this Power Flower is what we call it, is adopted and adapted for HCA's usage. This is a tool to show us that those who are furthest away from the privilege center are those most disenfranchised, and those with privilege are those with the most power. And they're often white, male, Christian, adult, rich, heterosexual, English speaking, and many other things that you can see at the center of this flower. Those who are furthest away from the center are most likely to be hurt by policies and programs if the policies and programs are not created with an equity lens. Oftentimes, policies and programs that we create or adopt will forget to address the consequences done to those furthest away from this privilege. Next slide. So we know that sometimes policies may be well-intentioned, but they end up not achieving that predetermined goal. We also know that communities most impacted are often not included in conversations. So if we want different outcomes, we have to work differently. Here's the challenge though. Our system was built without intentional equity for so long, and now we need to re-examine that system and not just remodeling it, because that's not enough. Instead, we have to dismantle some of those existing infrastructure, which requires time, energy, and resources. And we know that resources are finite. And since equity work is still fairly new in government work, we still don't have all of those resources readily available. So that's a barrier. Another barrier is that power shift. It can be really scary. We need to, and we are starting to shift that power and elevate community voices, but we have to move at the pace of the community. And then finally, government must make that commitment to address health disparities and reach for equity. We have to have that commitment. That is to say, we must change our culture and infrastructure. We can have all the equity strategies in the world, but culture eats strategy for breakfast, lunch, and dinner. So this is why it is so important that we must bolster our commitment to create that culture shift to advance health equity. Last slide. So as you know, the US healthcare system has come a long way, but it wasn't built for everyone. And a rising tide does indeed raise our ships. But if you're not in a functional ship, then you drown. So as my friend Yoda would have said, patience we must have, because we spent so many centuries building this system. It's going to take more than a few years to redesign it. So for today, I am asking the Commission to consider having this consistent equity framework, having that equity lens to help the Commission in its operation. Every time you make a decision, every time you vote on something, I ask that you consider this equity lens. I am happy to provide tools and resources such as the pro-equity anti-racism strategies, the health equity toolkit that we have, and various other tools as you need. So thanks for having me today. I'm going to pause here and see if you have any questions.
And we can turn back to the health equity toolkit just for the Commission's reference, that is in your materials, so that you have that as a potential resource for adoption when evaluating recommendations if the Commission chooses to do so at a vote.
I think we're pulling it back up. Slide
Yeah,
as well.
1 second.
All right, so I believe I would say thank you, Quinn, for and Mohammed, you have a question or comment for Quinn?
Yeah, thank you. It's not a question. I just wanted to basically show gratitude of this, the language you spoke, how you presented. Everything is what a lot of Americans and Washingtonians dream about, and it's often not seen. This is not the case, obviously, and we appreciate you presenting to us. And I will definitely use the toolkit to to continue doing my work. Thank you.
Thank you.
Joan?
Quinn, hi, it's good to see you. I just wanted to echo the thanks. I think the framework is largely consistent with the framework that we're using at the exchange to help kind of inform decisions, and that we were encouraged to sort of move forward with from our Health Equity Technical Advisory Committee. So this looks very consistent and familiar. My question in thinking through the motion to adopt and apply the framework is around sort of the level at which each individual member or commissioner would be doing that work versus the extent to which the equity impact would be noted as various proposals are brought forward. So looking to sort of understand the commissioner sort of level of responsibility to do that analysis for themselves versus the sort of analytic support that we're getting, and then how those fit together. So I'm not sure if there's guidance that could be provided from your work with other commissions or how you're working with other HCA staff.
Ask Mandy to take that one.
Sure, no problem. We'd be happy to do the initial analysis for the Commission for their review. There could be other potential things that the Commission could do in the future, but in the meantime, if the Commission we would be happy to perform that initial analysis and provide that to the Commission.
Thanks both.
And Mandy, so in terms of initial analysis, I'm looking at the toolkit. It is really cool. So when would the analysis be done? Right? Is it as each step? I'm trying to envision how you're doing the analysis gets integrated into the process that we're doing.
When commission members adopt a recommendation that they think might have a health equity impact, could perform the analysis.
So it's after we adopt or before we adopt?
Before.
Right. Okay. And would you want us to raise with you, can you look at this through an equity lens, or is the idea to build that analysis in without having to have an affirmative request?
Could build that in.
Okay, thanks.
I think I'm still looking for a motion. Yes. Is there a motion from anyone to adopt the equity framework and apply the framework to recommendations made by the commission?
I'll move.
Thank you, Jane. Is there a second?
Seconded. This is Emily Randall.
Thanks, Senator Randall. All right, further discussion by commission members about the motion that's on our screen right now to adopt the equity framework and apply that framework to recommendations made by the commission. All right, then I will call the question. All in favor, say aye.
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 Aye. Opposed?
I don't think I want to go there, so Representative Schmick votes no.
And any abstentions? Right, the motion is approved. So thank you, Quinn, again, for your work in bringing this and your work at the Healthcare Authority and advancing equity conversations and issues and frameworks in our state. So next, we're going to transition back to Liz, who will present on the revised work plan to incorporate some of the discussion of the Washington Health Trust Bill.
Great. I also see Joan has a hand up.
I just noticed that too.
Okay.
Hey, sorry all, I think I just dropped. So if I missed the vote, then pro motion, but it sounds like it passed, so you didn't need me.
Well, thank you for clarifying, Joan, and the record will reflect that. So thank you. We'll move over to Liz, Washington Health Trust Bill. Take it away, Liz.
Great. So just to remind everybody about where we are today, and where the trust bill is going to fit into our overall work over the course of the next year. Today we are talking about the transitional solutions. We're going to get a legislative update. We had a discussion about Medicare and provided some guidance on ERISA. At the last UHC, Universal Healthcare Commission meeting, we discussed that it would make the approach that we would take to incorporating the work of the health trust bill would be to run it alongside of the work plan that we currently have. And so to just show what that looks like to you, if we can go to the next slide, Angela. In August, the whole Washington coalition will be presenting on the trust bill. At that time, we'll be prepared to share a little bit more after that about key elements of the legislation and what it says about the different topics we're considering over the course of the year. So if we can go to the next slide, Angela. So for when we've crosswalked the bill, staff have crosswalked the legislation to the foundational elements that are included in our report, that was the report that was submitted to the legislature last year. And there are key points at which the legislation speaks to all of the pieces that we have identified: eligibility, benefits and services, provider reimbursement and participation, cost containment financing, infrastructure, enrollment processes, and governance. Also throughout the legislation are a number of recommendations around that would be considered transitional strategies. Following the presentation from Whole Washington, that will be sort of the launching point by which at future meetings, we'll be bringing in what the legislation says about topics that are being considered by the commission at that time. And beginning in 2025 and until the analysis is complete, we'll be folding in that analysis about the health trust bill into the annual report to the legislature. So that is the approach to the commission meeting its charge to address the health trust bill. So I don't know if there are any questions about this, but this is what the plan staff and HMA have come up with. And we'll probably adjust this following the presentation in August.
Any questions for Liz at this point? All right, well then, thank you, Liz, for the update. I'm next going to move us to several of our state agencies doing a legislative recap and a report out on the legislative session. We're going to start with insights. This will be from the Healthcare Authority, the Office of the Insurance Commissioner, and the Health Benefit Exchange in that order. So we're going to start with Evan from the Healthcare Authority.
Of course, thanks, Dave, and thanks everybody on the commission for having me today. Evan Klein, I'm the Special Assistant for Legislative and Policy Affairs, and I know many of you and worked really closely with so many of you during legislative sessions. So I suspect a lot of this material might not be new for the entirety of the audience. It's obviously great to see so many legislators on the call, but hopefully it'll be a helpful recap of some of the work that we participated in during legislative session, really with a focus on budget items and bills that I thought might have a good nexus to the universal coverage work that you're undertaking here. So you can go to the next slide. This is just a highlight of some of our agency priorities going into session. I think that there's a lot of overlap between what you see here and what I show on the next slide, which I felt kind of were the themes of legislative session. But thinking about investments in the behavioral health delivery system and behavioral health workforce, building equity through increasing access to care and transforming particularly how we pay for care, payment and delivery system transformation, some continued work around our Medicaid transformation project, obviously is a cornerstone of some of those efforts, technology investments in care coordination, and I'll touch on a couple of these, really thinking about how we start to bridge some of the connectivity across our eligibility systems, but also touching healthcare and social services, and then prescription drug affordability within broader affordability efforts. Next slide. And then here you can see kind of some of the themes that we took away from legislative session, some of the work that that kind of encompasses all the bill action and budget provisos that were directed of the agency over the past couple of months. And again, kind of the same themes here: behavioral health as a main focus, crisis services, affordability, financing, and coverage expansion, obviously included. Next slide. So one of the biggest items, we were directed actually to begin work on this program last year, and then the legislature invested program funds this year to continue that work. Is around Apple Health expansion, and this is the program that we are in the process of standing up to provide coverage to individuals who lack access to federal subsidies on the exchange or Medicaid coverage by reason of immigration status. It's looking to largely mirror the Medicaid benefit, focused on adults, individuals over age 19 and under 138% FPL, so that same income eligibility standard as is applied to adult Medicaid. The operating budget directed us to begin implementation last year and provided funding to start administering the program beginning July 1st of 2024. So we're excited about this. This is one of the largest uninsured populations in the state. So as we think about getting to universal coverage, providing insurance for individuals who lack access to Medicaid today, especially at that low end of the poverty spectrum, is really critical, but a lot of work ahead over the next year as we get the program rolling towards July 1st. Next slide. A number of investments in reimbursement increases, largely focused on ensuring access to behavioral health services. We know that workforce challenges, that we've seen a number of workforce challenges over the past couple of years, heightened by the pandemic, and more people with coverage, to be frank, right, who have access to behavioral health services at the same time. And so the legislature had invested some funds last year in a 7% managed care rate increase for behavioral health providers, and then added on top of that a 15% increase in managed care this year, as well as a 22% increase in fee-for-service. Fee-for-service wasn't included in the rate increase last year. So some significant increases for behavioral health providers, which we're optimistic will help to stabilize the workforce. We know there's a lot more work to be done there, but we're excited to work to get that money out the door to providers. And then, as you see here, a number of other kind of more targeted rate increases as well. Next slide. A couple of coverage changes, just for your perspective, thinking about what inevitably kind of gets covered by our benefit packages. There were some provisions focused on adult acupuncture and chiropractic coverage in the Medicaid program, as well as adult cochlear implant coverage, and then an adjustment to the hearing aid benefit in commercial insurance. And I don't know, Jane might touch on that a little bit more detail, but happy to answer any questions there might be, but just kind of breezing through a couple of these. Next slide. So, and then around IT and infrastructure investments, we saw some continued funding from the legislature around master person index. And this is allowing us as agencies to be able to identify somebody across different systems. So ensuring that, Emily Smith is an Emily Smith, right, as the same person across two systems. Integrated eligibility or enrollment and eligibility, again, thinking about how we can get people into the state's enrollment systems and then get them to the right forms of both healthcare coverage and social services that they need all in one portal. Electronic health records, there was some funding for us to procure an electronic health records platform, thinking about connectivity between healthcare providers and state agencies. And then some more work to be done here, but some additional language in the budget around community information exchange. And that's really focused on providers being able to connect to social services out in the community, but something that we're excited about. Just 3 slides here, kind of focused a little bit more detail on a couple of bills, the biggest of which is probably the hospital safety net assessment. The state already has a hospital safety net assessment, which assesses hospitals and then also relies on some mechanisms to draw down additional federal funds for investing in hospitals through the Medicaid delivery system. And that is set to expire or was set to expire in July 1st of 2025. So the legislature reenacted and adjusted that safety net program this year. It will direct us to implement a very significant directed payment to promote equitable distribution across hospitals through payments to managed care organizations that then go out as reimbursement increases. It also established a distressed hospital grant program that we'll have to administer as an agency. Next slide. And then the last 2 slides here, touching on 2 bills that didn't inevitably pass, but that we were pretty heavily engaged on as an agency this year. The first was agency request bill, House Bill 1269. This was a focus on kind of revisiting some policies related to the Prescription Drug Affordability Board. The PDAB was enacted last year. It's codified in RCW 7405 and is standing up a board here at the Healthcare Authority to look at the affordability of prescription drugs, and then inevitably in the out years, potentially set upper payment limits on some of those drugs, kind of focused on high cost drugs or those drugs with significant year-over-year rate increases. There was some work by the agency in conjunction with patient advocates and others to think about how we could strengthen this bill, especially relative to some of the other states that have enacted prescription drug affordability boards as well. Obviously, this bill failed this session, but We're hoping that it will keep alive a conversation about how we can continue to scrutinize prescription drug costs in the state and leverage any of the tools that are at the state's disposal to ensure that consumers are able to afford the drugs that they need access to. Next slide. And this is the last slide here is just around the Cost Transparency Board. There was a bill, this wasn't agency request legislation, but we were heavily engaged, House Bill 1508, that was thinking about kind of the next steps related to our Healthcare Cost Transparency Board and how we take the annual cost growth benchmark and start applying that as a standard to providers and payers across the state through enforcement mechanisms largely. So it was pulling from some concepts that have been implemented in other states, namely Massachusetts, around enforcement of a cost growth benchmark and thinking about application of that in Washington as a mechanism to try and control cost growth in the healthcare sector for the state. So we were engaged on this bill. It failed this year. We expect continued conversation with the legislature in the interim to come in next legislative session, but just wanted to highlight it here too. And that was it for my presentation. So I'm happy to turn it back or over to Jane or Joan.
I think Jane with OIC is next.
Thanks much, and my apologies, I don't have slides today, so you just have to look at my ugly face. Okay, so in terms of significant legislation that passed last session, Senate Bill 5338 directs the Office of the Insurance Commissioner to take advantage of an opportunity that was provided in federal rule in 2019 to update our essential health benefit benchmark plan. Essentially, that's the minimum benefit standard for all health plans that are sold on the exchange in the individual market and then also to small employers. So we have a request for proposal out for actuarial work to get that done. And we actually had our first big public meeting yesterday to sort of introduce the project out to the world. So we're well underway on that one. Evan referenced House Bill 1222. That is legislation that requires coverage of hearing instruments and services that folks need to be able to use hearing aids in the fully insured large group market starting January 1 of next year. Senate Bill 5242 passed, which basically says there will be no cost sharing for abortion services. And along with it, Senate Bill 5581 passed, which directs the Office of the Insurance Commissioner to do a large study as to how we can try to reduce or eliminate cost sharing for maternity care services. So prenatal care, delivery, postpartum care. That work is due back to the legislature July of 24. And then House Bill 1357 was legislation that was strongly advocated by the Medical Association and other provider groups. It puts tighter timeframes around the prior authorization timelines for health plans to respond when a healthcare service has to be approved by an insurer before it's actually delivered to somebody. That bill also has language in it, which we specifically requested, saying that the criteria that the health insurers use to figure out whether they're going to approve or disapprove a particular service for a particular person needs to be evidence-based, but also needs to be sensitive to equity concerns around particular impacts on particular populations. So actually, an example that came up yesterday through my email was somebody who was advocating for broader coverage of vitamin D deficiency testing by health insurers because African Americans are at greater risk for vitamin D deficiency than white individuals are. And so having basically health insurers need to acknowledge that when they're developing their criteria, their medical necessity criteria for services that have to be approved prior to actually paying for them, that there's recognition that different services have different impacts on different populations. And then we have a budget proviso that directs the Office of the Insurance Commissioner, along with the Attorney General's office, to put together a pretty large healthcare affordability study, looking at options through things like review of insurance rates, through a variety of other strategies to try to get at affordability of healthcare coverage, looking at things like consolidation across different kinds of healthcare providers, verticals, so hospitals buying home health agencies, buying physician practices. And we have a preliminary report due on that one to the legislature at the end of this year, and then a final report due in August of 2024. And not from this session, but from prior sessions. Some of you will remember that in 2022, the legislature passed a bill aligning our state's Balanced Billing Protection Act with the federal No Surprises Act. And the one gap in that was balanced billing protection for ground ambulance services. So we have an advisory group that we put together that's been working for the past 6 months or so. And we have a report and recommendations due to the legislature on that in October. So we anticipate that will get a lot of discussion. And then in addition, several years ago, the legislature made permanent coverage of audio-only telemedicine, so telephone use to deliver healthcare services. And the legislature directed us, along with the Healthcare Authority and the UTEP Telemedicine Collaborative, to bring back a report on what we've learned about use of audio-only telemedicine. And so that will be coming back to the legislature in November. And then the other issue that I think everybody is watching is pharmacy benefit managers. We had 3 pieces of legislation last year that related to pharmacy benefit managers. 1 passed, 2 didn't. And we've now had pharmacy benefit manager laws pass out of committees in both the United States Senate and the House of Representatives. So lots of attention to come, we think, on pharmacy benefit manager issues. And it's our understanding that there will be at least 1 additional bill on PBMs coming up next session. And then just to quickly note that 2 bills that did not pass last session were one that would have restricted the use of certain kinds of provisions in contracts between health insurers and providers that tend to be anti-competitive. And then another, this was actually Senator Randall's bill, that would have required the Attorney General's office to review and approve or disapprove mergers and acquisitions between healthcare providers. So that, in a nutshell, is what happened and what we're looking forward to also.
All right, thank you, Jane. I'll just add one. OIC also has newfound regulatory authority over pet insurance. I never forget to bring that one up for our furry family members. And Joan, why don't you take us to HPE?
I'd be happy to. I wasn't sure if I should talk or go to the slides. Let's go to the next slide. I think we can move through these pretty quickly. And I think it's a pleasure to go after Evan and Jane, because really this is going to touch on many of the topics they just mentioned. And then I can highlight some ones that haven't been mentioned yet. The next slide sort of shows you our legislative priorities for this session. The current slide shows you sort of our strategic plan, and we submit a report to the legislature every year that aligns with these priorities. The next slide sort of speaks at a high level about what our legislative priorities were for the 2023 session, and looking ahead to the conversation about transitional solutions. Some of these really advanced what is proposed or what are on people's minds on the FTAC, as reflected in the materials in the next tab. So we'll just highlight that, you know, the state has made sort of a unprecedented continued commitment to funding state subsidies that sit on top of the federal subsidies. for the lowest income Washingtonians. These are people who are churning off of Washington Apple Health right now as part of the Medicaid unwind. It's sort of helping people up to 250% of federal poverty, which in Washington is largely people making minimum wage who are make too much for Medicaid, but are obviously sort of face affordability challenges and being able to afford private healthcare. So the combination of the Washington Health Benefit Exchange runs Washington Health Plan Finder. Washington Health Plan Finder is the portal that about 2 million plus Washingtonians use to get their healthcare, either Medicaid or qualified health plans. We draw down about $600 to $700 million in federal subsidies to help people who are both low and middle income afford their health insurance. And then the state has sort of made an additional investment for our lowest income residents to sort of complement the federal funding that's available to really drive toward sort of high quality plans that are now under $10 to people who are lowest income to help them afford coverage and help catch them with coverage when they're coming off of Medicaid as part of the larger unwinding effort. So really thankful for that continued investment, really making a difference with people. We're already seeing it make a difference in who we're able to connect with continuous coverage coming off of Medicaid, which has been really exciting. We also had a lot of work focused on health disparities and expanding coverage. So we have a 1332 waiver. It's launching November 1, 23 for 24 that will, for the first time, expand exchange coverage to people who are undocumented. It's the first in the nation. So it's being watched pretty closely. We're excited about it. The legislature made continued investments in doing the outreach and the work we need to do with our federal partners to get ready for implementation of that waiver and do the reporting that we need to do and do the outreach that we need to do. This is in partnership with the program Evan described that expands coverage for people, under 139% of the federal poverty level. So we have a Medicaid expansion that takes care of people up to 138, and then we have a QHP expansion that takes care of everybody else. So we really do have sort of extended on this incremental coverage expansion in Washington to say anyone should be able to come through and buy a health plan if they need it. There's been continued focus on Health Plan Finder and how we can make that more inclusive and accessible to people. There's also been continued focus on some of these broader federal and state initiatives around coverage expansions. The next slide just steps you through sort of the level of investment in Cascade Care that we're seeing make a difference. It steps you through some of the activities that were funded to support the waiver implementation and just continued improved access in terms of interpretation and translation services, and some continued investments in Health Plan Finder. The next slide talks about the policy highlights. Again, you'll see what Evan and Jane just mentioned here, just in color. So the first is the Apple Health expansion that Evan mentioned for people up to 138. The second are the coverage and cost sharing mandates that Jane mentioned. There was sort of mandate palooza in the this legislative session, lots of mandate bills, some passed, some didn't. There's always that tension between requiring that additional services get covered or get covered for no cost, and then the resulting impact on premiums, potential impact on premiums. And we heard that debate play out over and over again this legislative session. There were the cost containment bills that both Evan and Jane mentioned. There were sort of 4 that were kind of moving and being considered together that didn't pass. And then what hasn't been mentioned so far that I think is folks can be mindful of, particularly as we're thinking about a Washington Trust or, this interoperability among all these different federal and state systems, is around data privacy. Sort of there's increasing protection that's needed around data. We're seeing Medicaid fraud kick up around the unwind, and bills that impact what data can be shared and with whom do have an impact on some of these or potential impact on some of these interfacing health systems. So we're mindful of and watching those as well. The next slides I'm not going to go through. I'm just going to show you that they're here in case it's of interest. So you can see the bills we were tracking in the coverage mandate, the cost sharing mandate category that did pass. The next slide shows you some of the oversight and financing and data privacy bills that did pass. And then the next couple slides show you the bills. Jane referenced some of these numbers, so they're here if you need them, that didn't pass. There's some coverage mandates, some cost sharing mandates. The next slide shows you that kind of suite of cost containment bills the data privacy rights charter, and then the last shows you just some of the miscellaneous bills we're tracking, including the Washington Health Trust bill, which everyone here is familiar with. So looking forward to continued discussion there. If anyone has questions, let me know, and I'll turn it back over to Dave.
Marcus?
Not a question, but I did have a comment, if that's okay.
Sure.
Okay. Well, I just wanted to really point out with the work we're doing, also the cost containment bills, how they face significant headwinds. I think that is something to recognize for this group as we're looking at the work FTAC's doing and just how we try and move people in the legislative process and move the public, that there are significant headwinds. And then I hope too that commission members will see that those, I think, actually are important types of pieces of legislation to be tracking and looking at. So that's my editorial pitch there too, because I think it's all really connected to some of the goals that we have here.
Certainly interconnected. Appreciate that.
I vote that next year we have the legislative members give the legislative session roundup. I feel like it would be more interesting and have a lot more fun color commentary in it.
Well, my only color commentary was there was a bill way down that I worked with Jane on the preventative services, and that was introduced way past any. So to have it on the not passed list, I was like, well, it was introduced post when it could have been considered. So those are some of my editorial comments. They would have just been, cheeky, really.
Well, actually, I meant to mention that, Representative, that there is, many of you have heard about the Braidwood decision that came out of a federal district court in Texas that basically said that insurers did not have to cover certain preventive health services under the Affordable Care Act. That decision's on appeal to the Fifth Circuit, United States Court of Appeals. It will very likely make its way to the United States Supreme Court. And we have a comparable provision in state law, but it needs to be updated. So we appreciate Representative Riccelli dropping the bill. It's House Bill 1855 at the very end of this past session so that it can be taken up at the very beginning of the next session. So we'll be working on that.
I'm going to transition us to our last topic for the day. Just for clarity, our slides have that we may vote on something, but I think it's a bit much to ask people to rush through this part. So Liz, I'll just have you do some of the preliminary conversation and get our minds thinking. And then our homework for next meeting, while I have the chair gavel, is to be able to identify specific topics to bring motions next meeting. So Liz.
Yes, and I will be brief. I know folks probably want to get on with their day here, but we wanted to circle back to one of the key charges of the commission, which is to look at transitional strategies and begin to start prioritizing where you want to spend your energy over the next year. So if we can go to the next slide. And I just want to say, like, the conversation that we just had and hearing from the different agencies about everything that happened and didn't happen over the last legislative session is really such a nice entry point for this conversation, because you kind of see where a lot of the energy is. I think I want to give kudos to the commission, because many of the recommendations that you made in your report last year were adopted, and that's great. You have a lot of what you put in your reports is being considered. So I think that's where this transitional solutions conversation comes in. So just to kind of recap what we've been doing on this, at the very beginning of this year, we surveyed the commission members about different transitional solutions that they thought would be important for this commission to consider. They also asked, you all also asked for the FTAC to provide some insights on different areas that they thought could make a difference in paving the way towards the goal of universal coverage. And then the next step was to be prioritizing these different areas or different policy solutions for further study. So if we can go to the next slide. So that's what you see on this slide. This is a roll up of all the different policy options that we heard either from you or from the FTAC. And they're bucketed into different categories. You can see across the top: affordability, cost containment, pricing, et cetera, et cetera. Underneath of each of those categories, you'll see specific policy ideas. And if you go to the next few slides, there's 3 more slides that actually just, they're just smaller. And there are some questions on the bottom that we'd like for you to think about. We don't have to answer them today because we don't have enough time. But when you're looking at these buckets, is there anything that's missing? Is there a policy that's missing? And from your perspective, what makes sense to focus on? And it could be, you could either be looking at specific policies in the light blue, or you could just be focusing on the blue categories at the top. So that's just to orient you to what we're hoping can provide you some a framework for how we're going to come back and decide where to prioritize for looking at transitional solutions. So if you want to just flip through the slides, Angela, so you just kind of see what you're looking at. So again, the big buckets are the darker blue, and then underneath our key policies, some of which we just heard about in the recaps. And you can keep going through this, Angela, just kind of showing everybody. You can see these continue on each. And so we would just ask you to take a look at this, think about what's missing, either from the big bucket level or also within those buckets, what also might be missing. And then from your perspective, where do you think the commission should be focusing its energy over the course of the next year? What do you think can make the most difference? What do you think can pave the way towards where the commission wants to go over in the next few years? So I think that's the framing. I don't know, Mandy, Angela, or Dave, how you want to direct the commission at this point. Are we going to do this via email, or are we going to do it at the next meeting?
Cool. Thanks, Liz. That's perfect kind of summation for this the transition on transitional solutions. I kind of said a little tongue in cheek about our homework assignments, but we will be bringing this back at the next meeting for further discussion. And so it could be helpful for people to get a jump start on their homework because we'll be bringing it back to the commission at the August meeting.
Great.
So, and Dave, just one thing from Jane, I know I'm happy to make this offer. If it would be helpful to the commission, we have several reports, studies that are coming up between now and the end of the year. So we have, for example, there was a reference here to telehealth. We have the audio only telemed study. We have the ground ambulance balance billing study. We've contracted with the all payer claims database to do a deep dive into access to behavioral health care in the private health insurance market, and that should be available in October. And then we have a preliminary report due to the legislature on the healthcare affordability study in December. So we're more than happy to share whatever we come up with. And then we have the essential health benefits update report that's due at the end of the year as well. So we're happy to share what we come up with on those reports with the commission if it fits in with sort of what we're thinking about when.
Thank you, Jane. I can follow up with you on that particular topic, and I'd be happy to touch base with you and keep in touch with you as you generate those reports.
Okay, doke.
All right, I'm going to wrap us up and thank everybody for attending today. The recording and summary of the meeting will be posted shortly on the HCA website. Thanks again to our presenters. Our next commission meeting is August 10th at 2 p.m. Thanks for bearing with me as I chair my first open public meeting. I look forward to seeing everyone at the next meeting.